I think we shall start. Okay. Doctor, just hold on 1 minute. Doctor.
Hello, Professor Kato.
Hi, how are you? Thank you very much for your contribution. So
thank you for the invitation.
Thank you very much for every time you support ACNS.
Thank you.
This time is for us. Thanks so much.
I am not sure who. I think there are two more speakers. The nurse speakers are not in yet. I think due to some connection, they are not able to connect. Shall we start, Prof. Kato?
Yeah, I think so. Yes.
Okay. Good morning, good afternoon, good evening to Professor Yoko Kato, all speakers, chairs, and moderators, and of course, all audiences. Welcome to the 11th ACNN webinar. Today, our speakers are Professor Gidion from Beijing, China, Miss Karen, and Sister Dorcas and Magawa from Tanzania. Our chairs will be Matron Liu Miao, Professor Dr. Aisha, and our moderators will be Dr. Nasmin and Dr. Brian Salazar. So I think I would like to invite Professor Yoko Kato to give a few words before we start the webinar.
Okay, thank you so much. So today that we can hear the very excellent lecture of the Igao about trauma, regarding trauma. So the trauma is very important, especially in Asia. So we are very much expecting your lecture, and also the Magawa from Tanzania. She is coming to my place in very near soon. Thank you very much. Thank you, Yi.
Okay, thank you, Professor Yoko Kato. Now I would like to call upon Matron Liu Miao to introduce Professor Gidion as a first speaker on the topic traumatic brain injury. Please, Matron.
Hello, everyone. Hello, I'm Liu Miao.
Hello, how are you?
Hello, I'm Liu Miao from Beijing Tsinghua Chang'eng Hospital, Tsinghua University. It's really honor to be here in this session. We invite Dr. Guo Yi, who is Senior Neurosurgeon of the Department of Neurosurgery, Beijing Tsinghua Chang'eng Hospital. He mainly focuses on cranial cerebral trauma and cerebrovascular disease. His topic is traumatic brain injury. Dr. Guo, please.
Okay, thanks for the introduction, Liu Miao. And dear Professor Kato, Matron Chang, thank you very much for having me. And it's my great honor to be here. And I'll share my screen first. Oh. Okay, can you see my screen?
Yes, Prof.
Okay. Good evening, everyone. Today, I'd like to share with you about the traumatic brain injury. And in my presentation, I'll focus on some basic concepts and knowledge of traumatic brain injury. It will take about 30 minutes to cover this issue. And a traumatic brain injury is a very common disease. It's an injury which results from trauma to head due to external physical forces. And it is one of the most common causes of disability and death in adults. And it is a significant concern to public health and rehabilitation professionals because it is associated with both acute and long-term disabilities. The two most common causes of traumatic brain injury are falls and road traffic accidents. We all know the brain is the most complex structure organ in human, but gross head anatomy is simple as this illustration. The brain is the central part of the delicate neural tissue. It is easy to injure without the protective layers. The protective layers starting with the superficial scalp and the bony structure of the scalp, and then the meninges that comprise three layers. It is very similar to walnut. Today, I will mainly focus on four types of traumatic brain injury, including epidural hematoma, subdural hematoma, brain contusion, and penetrating injury. And let me start with three most common traumatic brain injury cases in clinical scenario. The first one is a 21-year-old male. The patient was punched in the right temporal area 2 hours ago and immediately became unconscious. And after 10 minutes, he regained consciousness with nausea and headache. His vital signs were stable and there were no neurological deficits when arrived at the emergency department. PET-CT shows a small right temporal intracranial hematoma. After observing for 5 hours, the nurse found that the patient was unresponsive, and the GCS was E1, V1, and 5, and his pupils were unequal. The right pupil was 4 millimeter, and the left pupil was 2 millimeter. In the repeated CT scan, we can see the intracranial hematoma in large. So there is four questions here. What is the mechanism of the injury and the diagnosis based on the CT scan? And what is the characteristic of this case? And during the observation, what is the precaution we should know? And the second case is a 37-year-old male. The patient accidentally fell to the ground from 2 meters roof 3 hours ago, causing his head hit the ground with occipital impact. He was loss of consciousness immediately with vomiting and urinary incontinence. When he was transferred to emergency room, he was still in comatose status, and the GCS was E1, V1, and 5. Both pupils were equal with 2 millimeters diameter. And also there was three questions here. What is the mechanism of the injury for this patient? And what is the diagnosis based on the CT scan? And what is the characteristics of this case? And the next case is a 69-year-old male. The patient was hit by a car when riding bicycle 5 hours ago, causing his head hit the ground with occipital impact. He was loss of consciousness immediately with vomiting. When he was transferred to emergency room, he was still in comatose status, and the GCS was E1, V1, and 4, and both pupils were equal. So also we have three questions here. And first of all, let's give a brief review of a mechanism of head injury. Acceleration injuries occur when the force impacts the head and the head moves without restraint. During an acceleration injury, brain tissue and structures compress against each other. And the acceleration injury is when a moving person comes to an abrupt halt and the brain within the skull still has forward momentum and hits the inner surface of the skull, causing injury. And whiplash injury is an injury that happens when sudden force of movement strains your neck and spine, damaging bone, muscle, ligaments, and nerve. It is commonly caused by rear-end car accident. They also happen as a result of sports injury, particularly during contact sports. The most cranial cerebral injuries seen in the emergency department are caused by acceleration, deceleration, or direct impacting mechanism. But crushing injury to the head is the less common seen. A crushing injury occurs when a body part is subjected to a degree of force or pressure, usually after being trapped between two heavy objects, often resulting in multiple skull fracture and injury to the cranial nerves and the blood vessels. And blast injury often happens in war. It is divided primary, secondary, tertiary blast injuries. And the primary blast injuries result from the high pressure or blast overpressure created by explosions. Blast overpressure can crush the body and cause internal injuries. And secondary blast injury result when strong blast winds behind the pressure from the propel fragments and the debris against the body and cause blunt force and penetrating injuries. Tertiary blast injury result from strong blast winds and pressure gradients that can accelerate the body and cause the same types of blunt force injuries that would occur in a car crash and fall. So the primary impact causes coup injury. It occurs beneath the point of impact, often associated with a skull fracture at the site of impact. And secondary impact causes a contra-coup injury. It occurs when the impact is sufficient to cause the brain to move within the skull. The brain moves in the opposite direction and hits the opposite side of the skull, causing bleeding. And this is often happens in the inferior frontal and the temporal lobes and associated subarachnoid blood. So now we come back to the cases. According to the medical history of the first patient, he was punched in the right temporal area, which is an acceleration injury. The primary impact can cause the coup injury. So the CT scan is the most common imaging modality to assess for intracranial bleeding for such emergent cases. So on the CT scan, we can see the blood collects under the right temporal bone, which is epidural hematoma, and it appears as a dense mass and pushes the brain tissue away from the skull, especially 5 hours after admission. The classic presentation of epidural hematoma is a biconvex or lens-shaped mass on brain CT scan. This is because the limited ability of blood to expand within the fixed attachment of the dura. When a person has an epidural hematoma, they experience a brief loss of consciousness after the head trauma, and this is followed by a period of alertness that may last for several hours before a loss of consciousness and the brain function decline. And most people with epidural hematoma follow the same pattern. So we need to keep in mind of this unconsciousness, regain consciousness, and loss of consciousness again pattern during the observation. So according to the medical history, mechanism analysis, CT scan results, this patient was diagnosed epidural hematoma. The epidural hematoma occurs in up to 10% of people with head injuries. About 75% of epidural hematoma in adults happen in the temporal area of the brain, just like this case. And many epidural hematoma follows the typical disorder of consciousness pattern of the coma, alertness, and the coma again. It is often termed as a lucid interval. The classic lucid interval occurs in pure epidural hematomas that are very large and demonstrate a CT scan finding of active bleeding. The presentation of symptoms depends on how quickly the epidural hemorrhage is developing within the cranial ward. A patient with a small epidural hemorrhage may be asymptomatic also, and epidural hemorrhage may develop in a delayed fashion. The patient sometimes exhibit agitation, aberrant motor behaviors like hyperactivity, non-purposeful movement, and combativeness with decreased consciousness that are disruptive to patient care might be a red flag that increased the intracranial pressure caused by active bleeding. So this is another key point of observation. And epidural hematoma is a neurosurgical emergency. It requires urgent surgical evacuation to prevent irreversible neurological injury and death secondary to hematoma expansion and herniation. If some warning signs be observed by nurses, you should inform the doctor to check the patient immediately. And here is some indications for epidural hematoma surgery. Hematoma volume greater than 30 milliliters regardless of Glasgow Coma Scale score. And we can estimate the amount of blood on CT using this formula. On CT and midline shift of more than 5 millimeter and GCS less than 9 with pupil dilated. And now let's see the second case. So what is the mechanism of this injury of this patient? From the medical history, we know the patient fell from the roof. This is a deceleration injury. Usually it causes a croup injury and contra-croup injury. The patient had hit the ground with occipital impact. From CT scan, we can see the right occipital bone fracture and a small epidural hematoma just under the fracture. So this is the croup injury. It came from the primary impact directly. And he had the left subdural hematoma. The brain was compressed and the left ventricle was getting small and the brain midline shifted severely toward the opposite side. These are the contra-croup injury from secondary impact. A subdural hematoma, as its name implies, forms because of an abnormal collection of blood under the dura mater. The decelerating forces, of course, is the brain to move in an opposite direction to the meninges, causing the bridging veins to rupture and bleed collect in the subdural space. He had injuries with sudden serious bleeding causing subdural hematoma. The person may pass out right away, or even go into a lasting coma. In acute subdural hematoma with a thickness greater than 10 millimeter or a midline shift greater than 5 millimeter on CT scan should be considered surgically evacuated. Also, GCS score decreased during observation by 2 or more points, or the patient presents with asymmetric or fixed and dilated pupils, or the ICP monitor exceeds 22 milliliters of mercury. So it is often said the eyes are the window to the soul. And in neurosurgery, we can say pupils are the window to the life. The patient's pupil can reveal the severity of the brain injury and the intracranial pressure. Here we can see the pupils dilated in different stages of increased intracranial pressure. If intracranial pressure increased extremely high, it will cause a brain herniation. The brain tissue is displaced by high pressure, just like toothpaste is squeezed out of the toothpaste tube. This is an emergency situation which is needed to be decompressed right away, or brain does not get enough blood and oxygen. It will develop secondary ischemic brain injury. Herniation can cause brain death due to irreversible brain stem dysfunction or damage to the brain's respiratory and cardiovascular centers that causes respiratory or cardiac arrest. Now we come to the third case. The patient was hit by a car when riding bicycle and has an occipital impact too. So it is also a deceleration injury. So from the 3D reconstructed CT, a bump can be seen on the right occipital area. It is a scalp hematoma, and it is the marker for us to know the location of the force impact. And a linear occipital bone fracture extended from right to left, which is also an indicator of the location of the impact. This patient had a left frontal temporal brain contusions. Brain contusions are scattered areas of bleeding, most commonly along the undersurface of and poles of the frontal and temporal lobes. They occur when the brain strikes the sphenoid ridge on the skull. So indications for surgical removal of brain contusion include the progressive neurological deterioration, signs of a mass effect on brain CT, and unresponsive increased ICP midline deviation of more than 5 millimeter, and the cistern compression evidenced on brain CT, and temporal contusions of greater than 20 cc of volume. And this is a simple procedure when the patient of traumatic brain injury admitted. The patients are assessed and their treatment priorities are established based on their injuries, vital signs, and injury mechanisms. Logical and sequential treatment priority are established based on the overall assessment of the patient. The patient's vital functions must be assessed quickly and efficiently. The management consists of a rapid primary survey with simultaneous resuscitation of vital functions. The primary survey identifies life-threatening conditions by adhering to the ABCDE's sequence. Also, we can follow sample procedure, the principle to acquire the information, asking the patients or the relatives. To do a rapid neurologic evaluation establishes the patient's level of consciousness with GCS score and pupillary size and reaction, identifies the presence of lateralizing signs and the focal neurological signs, and determines spinal cord injury level. Then following to order an emergent CT scan. The last part is that we give a brief review of penetrating brain injury. The penetrating brain injury includes all traumatic brain injuries which are not the result of a blunt mechanism. So the protective barriers of the brain, including scalp, skull, and meninges, are breached. Head injuries, of course, is caused by penetrating trauma, serious medical emergencies, and may cause permanent disabilities or death. It is a significant challenge to practicing neurosurgeons. And based on the speed of penetration, it can be classified into two categories of high velocity and low velocity penetration. The high velocity penetration often caused by bullets or shell fragments from direct trauma or shockwave injury to surrounding brain tissue. And low velocity penetration are often caused by a knife or other sharp objects with direct trauma to brain tissue. And because of the presence of contaminated foreign objects, the skin, hair, and bone fragments driven into the brain tissue, infectious complications are common after a penetrating brain injury, and they are also associated with higher morbidity and mortality rate. And the risk of post-traumatic epilepsy after penetrating brain injury is high, probably due to direct traumatic injury to the cerebral cortex with subsequent cerebral scarring. And CT scan is recommended as the neuroradiology modality of choice, and angiography is recommended when there is a high suspicion of a vascular injury. And treatment principles include for the penetrating brain injury includes debridement and making open injury, change it to close the injury, and then follow the principles of treatment principles of closed injury. So the next are some penetrating injury cases we treated. And this patient is slashed with knife, and the bone, we can see a bone fragment was into the brain on the CT scan. And this patient was injured in a car accident. The brain tissue squeezed out of the skull through frontal bone fracture. And this is a suicide attempt case. The patient also had a stab wound in abdomen. And this patient was injured in a motorcycle accident. And we can see a bone fracture of the right frontal bone and a foreign object here. But after the surgical exploration, we can see this foreign object is another rider's teeth, penetrates the patient's skull and dura and remains lodged in right frontal lobe. And this patient was died from the uncontrolled the brain abscess. And these are some low velocity penetration cases with different foreign objects like a medical needle holder, steel bar, and keys. And gunshot injury is very rare in China because of the very extreme policy of the gun ban. The CT scan, this case is a gunshot injury. The CT scan showed a compound expansile skull fracture with multiple bone fragments along the trajectory in left occipital and a bullet located in right frontal lobe. And he underwent left occipital and right frontal craniotomy, debridement, including removal of the superficial intracranial bone fragment and removal of bullet. The patient recovered well, but he had a persistent hemiparalysis. So for severe traumatic brain injury patients, intensive care is the most useful management, including multi-model protocolized approach involving careful hemodynamic support, respiratory care, fluid management, and other aspects of therapy. It requires the efforts of a multidisciplinary team, including neurointensivists, neurosurgeons, bedside nurses, and respiratory therapists, and other members of the medical team. And this is the ICU setup in our hospital. Well, that's it from me, and thanks for your kind attention.
Thank you, Professor Guan, for the comprehensive lecture. May I now call upon Matron Limau to invite the commentators to give any comments or any opinion.
I want to ask Gao. Thank you very much for a wonderful talk. Thank you very much. Can you hear?
Yes.
Yeah, thanks so much. So I think the indication for the treatment or surgery, just we can maintain about cerebral perfusion pressure. So I think it's very, very important, the role for the neurosurgeon, I think. So I think sometimes we can not in time for the patient to save the life. So when do you decide the indication of the surgery? As soon as possible, or sometimes can you wait for make a decision? Hello, can you hear?
I'm sorry. the connection just broken. I'm sorry.
Okay. So the when do you decide the indication for the surgery? So immediately you see the CT, or sometimes you can wait.
Yes, we have two aspects of for our decision. One aspect is for the experiments, like the pupils of the patient consciousness level and the CT scans to judgment for the intracranial pressure. And we also insert the ICP monitor for the patient, the GCS score lower than the 8. And if the ICP pressure increased continually more than 22 millimeter mercury, and combined with the CT scan findings for our judgment for the surgery.
Okay, thanks so much. One more question, okay? So just
yes,
apart from the acute stage of the injury, just I'm asking the chronic subdural hematoma is okay? That is one of the chronic subdural hematoma, not acute. Chronic
I'm
subdural
sorry.
hematoma. Yeah, can you understand? Chronic subdural hematoma.
I don't follow.
Chronic subdural hematoma.
Okay, chronic subdural hematoma. Yes. Yes. We use endoscope to remove the chronic hematoma. If some clots, we in the direct visual to remove it.
Okay. So what is the advantage of the endoscopic evacuation of the clots or chronic subdural hematoma?
Yeah, traditionally we just drain the hematoma, but now we tried to use the single burr hole and to advance the endoscope to see the subdural cavity, and if the hematoma has some left there, so we tried to remove it. And now we tried to develop like soft robotic arms with our university scientists for such single burr hole surgery, not only for the chronic subdural hematoma, but other surgeries. We tried to talk about this feasibility and try to develop such technology for the future.
Wonderful. That's minimally invasive surgery, minimally invasive treatment for the patient. Thank you.
Yes.
Thank you.
Thank you. Thank you, Professor
Thank you very
Kato.
much.
Good evening. Yeah. Thank you. I'm Christine. Right now, we will move to the second session. I would like to say thank you to all the speakers for the session 1. Now, I will introduce the Professor Asa as a chair for the second session. Professor Asa as a Director State Institute of Medical Education and Technology, Kerala, India. Professor Asa, are you ready? Yeah. Hello, Professor Asa. Are you there,
Christine,
Professor Asa?
Christine,
Yeah. Yeah.
can you
Yeah,
hold
Miss.
on first? Christine, can you hold on first?
Oh, okay,
That
okay.
question for Professor Yuan. This is a doctor from India and currently a fellow in Fujita University. The question is, what is the ideal time to do repeat CT scans when you see a small ETH or SDH? Is it every 6 hours or every 12 hours? Prof. Yi?
Yes. The first repeated CT scan, we set up regularly the 6 hours after the first CT scan. And then if the patient stable, and we extend the time interval to the 24 hours. And mainly we our nurse to monitor the patient status. If something changed, we will do the emergent CT scan.
Thank you, thank you. May I call upon Dr. Nasmin to as commentator to give your comment, please, Dr. Nasmin?
Yes, I am hearing. Can you hear me?
Yes, yes.
Okay, first of all, I want to convey my thanks for giving me the opportunity to say something in this important webinar. And also thank you, Professor, for your brilliant presentation. And you have briefly reviewed all the segments of traumatic brain injury. In your presentation, you have mentioned the surgical indication. So in some cases of traumatic brain injury, we also went for conservative management. So my question is, what is your concept to, what are the agents you prefer to control the raised intracranial pressure in case of traumatic brain injury? The agents you prefer, whether it is mannitol or hypertonic saline. I want to know in your setup.
I'm sorry, I didn't follow you. Can you repeat the question?
Okay. I am again asking you, what is your preferred agent to control the raised intracranial pressure in traumatic brain injury, whether it is mannitol or hypertonic saline? What is your preferred agent and why?
Yeah. Now we also use the mannitol. Well, I prefer the mannitol, but we tried in some patients for the how to say that the saline, right? The 3% is the saline, and but now we use the mannitol mainly.
But there are some contraindication of mannitol, right? Like if the patient has heart failure, if the patient has acute kidney injury or features of pulmonary edema, we didn't go for mannitol. So in that case, do you routinely practice hypertonic saline?
Yes. Our ICU teams, and they use hypertonic saline, and based on the clinical experience and the guidelines. And but for me, and I mainly focus on the surgical. So my resident and our ICU teams, the attending doctors, they use mannitol and hypertonic saline both.
Okay. Thank you very much.
Thank you.
Okay, thank you, Dr. Nasmin and Prof. E for the excellent presentation. For the second session, may I invite Miss Christine to handle the second session? Christine?
Yeah. Yeah, okay. Thank you, Mikir. And for the second session, as the chair, Professor Asa. Professor Asa. Okay. Good evening, Professor Asa. Yeah, I have already introduced yourself. Please, this is the time for you to lead for the second session. Please, Professor Asa.
Okay. Good evening to all. Greetings from India. And first of all, let me thank the organizers for giving me an opportunity to be a part of this 11th ACNN webinar. And this session is on traumatic brain injury. And the second session is on nursing perspectives of traumatic brain injury. We have two speakers. The first speaker is Ms. Karen S. March. She is currently a nurse consultant in Marburg Research, and she has worked in various capacities in nursing, from staff nurse, charge nurse, specialist nurse, clinical faculty, and director of clinical development. And she is a graduate from in nursing from Whitner University and had her master's in nursing and she specialized in critical care pathway from University of Washington. She has also undertaken few liberal arts courses, and she has received several certifications, including emergency neurologic life support. And she is an alumnus of certified critical care nurse, and she is a certified neuroscience nurse, and she is ACLS certified and course director and instructor in advanced trauma nursing. And she has undertaken various research projects in neuro and trauma nursing, and she has more than 35 publications in influential and scholarly journals. She was a publication reviewer for many journals and textbooks in nursing too. And she has secured various awards and special recognition like ANN Leadership Awards, Marshall Research Grant Award, an Outstanding Young Women of America Award. She is very active and in professional associations and undertaken various professional activities too. And she has represented the institution and country in many conferences and symposiums abroad. So with much delight, I welcome Ms. Karen S. March to present the topic, Traumatic Brain Injury, Nursing Perspectives. Please.
Well, thank you so much for inviting me. Can everyone hear me okay? Yep. Okay. Well,
Yes,
great.
yes.
So I'm going to talk about the nursing perspective of traumatic brain injury. So my goal is we'll just briefly in a few slides talk about the incidence and causes and how variable they are globally. And also then we'll focus on the perspective of caring for the traumatic brain injury. And I'm going to focus mostly on severe traumatic brain injury. So we know that road traffic accidents are the leading cause of death in the young, age 5 to 29. And over half of road traffic accidents result in traumatic brain injury. In low middle income countries, this is most commonly fatal. Of traumatic brain injury, 75% of them will be mild traumatic brain injury, and we're not going to focus on that. So in this slide, what you see is really talking about the variability and mechanism of injury. And what you will see is that in many countries, developing countries, low middle income, and some high income, you will see that road traffic accidents are the majority. And this is from a recent study that looked at what were the mechanisms of injury. But you'll notice that in Europe and in the United States that it's now falls that are the major cause. And that's in the very young and the elderly. And so it doesn't always have to be a fall from height to be a result in a severe head injury. So let's talk about the nursing perspective. And I want to take it in using the acronym ABCDTP. So we're going to talk about managing our airway and oxygenation, breathing and ventilation, circulation and perfusion, disability, which is going to be our neuro assessment, and a few other things that we need to keep in mind. Temperature management and really focusing on maintaining normothermia and avoiding fever. And then P is positioning and prevention of complications. So with our airway, we know that hypoxia increases morbidity and mortality. So as the nurse, we need to be monitoring our patients to prevent hypoxia. And I'll talk more about that in a second. We need to establish airway control. So if the patient is not intubated, we may need to bag valve mask and prepare for intubation. Our severe traumatic brain injury, Glasgow Coma score of less than 8, should be intubated to control their airway so that we avoid hypercarbia and hypoxia. In these patients, we should also put an oral gastric tube in them. And we do want to do this orally, especially when we do not know the status of whether or not they may have some basilar skull fractures, which could, if we put a nasogastric tube, result in the tube going into the brain. So our goal with our airway is to maintain adequate oxygenation. So we can monitor our saturation. We want to keep that greater than 90 to 95 with a PaO2 of around 100 or greater. We need to maintain a clear airway and suction our patients' PRN. And sometimes we worry about suctioning our patients because of the fact that it may result in an increase in intracranial pressure. But in most cases, that is not sustained. When we do suction our patients, we want to have a sterile or, if not possible, clean catheter, hyperoxygenate pre and post suction. We want to avoid the use of saline. This has been something when we have thick secretions, often nurses want to install saline down the endotracheal tube to try to loosen up those secretions. But studies have found that really this causes further issues with the mucus plugs being pushed further back down into the alveoli. So if we do have a patient who has increased intracranial pressure that's sustained, there are 2 agents that are have been found useful. One is dexmedetomidine and the other is lidocaine, and these are both safe and effective ways to manage intracranial pressure. So with breathing, we need to think about our CO2. Hypocarbia, hyperventilation can result in cerebral ischemia, and hypercarbia may result in cerebral hyperemia or vasodilatation of the vessels, which may lead to increased intracranial pressure. So when we are ventilating our patients, it's useful to have an end-tidal CO2 monitor so that we can trend what is happening with our CO2, keeping with the goal of keeping our CO2 between 35 and 45. We want to avoid hyperventilation unless our patient is showing signs of acute herniation. And so we're looking for signs such as the patient decerebrating or decorticating with unilateral or bilateral fixed and dilated pupils. When we do hyperventilate that patient, it's going to be a temporizing measure And one of the things that we can monitor to say when do we stop is to watch the pupils. If the pupils size starts to decrease or the pupils become more reactive, we've relieved the pressure and therefore we can stop hyperventilating. We also want to avoid prolonged prophylactic hyperventilation because that may lead to further ischemia. In order to properly ventilate our patients, we often will need to use sedation and analgesia in order to keep synchronous ventilation. Because of the use of sedation, we know that the goal is to try to get patients extubated as soon as possible, but in a severe traumatic brain injury, often this is not possible, and that we talk about sedation vacations in many of our critical care patients, but in this population, we usually want to take a look at the intracranial pressure. The physicians will give us the guidance of when we want to withdraw sedation to see if our patient is ready to be extubated, and that's usually based on what their neurologic status is or whether they have evidence of increased intracranial pressure. Another thing that we want to do is make sure that we are providing evidence-based ventilator-associated pneumonia protocols in order to try to prevent the increased incidence of pneumonia. So now we're going to talk about circulation. Just as we talked about hypoxia is bad for the brain and can increase morbidity and mortality, hypotension can double our mortality. So anytime during that acute phase. So on this slide, what you see is in the adult, the systolic blood pressure of less than 90 is our definition of hypotension. And in the pediatric age group, there's sort of a sliding scale with infants being less than 60. And then as we get up to school age and adolescence, we get closer to values that are similar to the adult at 80 to 90. There have been some goals for blood pressure and where we want to keep our blood pressure. That was published in the last edition of the Traumatic Brain Injury Guidelines in the United States. And that is a systolic blood pressure of greater than 100 should be maintained for patients who are age 50 to 69. And for the patients who are 15 to 49 and over 70, we want a slightly higher systolic of greater than 110. Oops, excuse me. We talked a little bit before about cerebral perfusion pressure. So if you have an intracranial pressure monitor, you can actually calculate cerebral perfusion pressure. That's mean arterial pressure minus mean intracranial pressure to equal our cerebral perfusion pressure. So CPP in an adult is normally around 80, and with children slightly lower, although the adolescent's normal is often a little bit higher of somewhere around 85. The absolute values in children are not well established. We know that ischemia is less than 40. We want to make sure that we maintain a CPP of greater than 50 to around 70 millimeters of mercury. We want to establish euvolemia. So we're going to look at our fluid intake, and that's typically with an isotonic solution, so normal saline or lactated ringers, or it may be also hypertonic saline. We want to avoid hypotonic solutions, such as dextrose, and also colloids, because they may lead to increased intracranial pressure. The way to monitor for our fluid status, a good indicator of our resuscitation, is to monitor our urinary output with an indwelling urinary catheter. And our goal should be to have a urinary output of 0.5 to 1 milliliter per hour. So if per kilogram per hour. So if most patients, it's around 30 cc's per hour. So that means we need to be looking at the urine outputs every hour. We also need to monitor our electrolytes. We're patients to make sure that they are not, we don't want hyperglycemia or hypoglycemia. Both of these can be detrimental. We want to monitor electrolyte, our coagulation panels, our hemoglobin hematocrit. The literature suggests now that we do not want to keep a hemoglobin too much higher, push it higher than 7. However, this is a bit controversial in the neuro patient because we worry about the cerebral ischemia. Our patients are very vulnerable. So some intensivists and neurosurgeons disagree with the general trauma data to say to monitor somewhere around 7 milligram per deciliter for a hemoglobin or 21 for a hematocrit. So when we look at then monitoring our disability, and our previous speaker spoke about this, neurologic assessment is imperative. The nurse is really the one at the bedside, so she needs to do frequent neurologic assessments, and that includes pupils, Glasgow Coma score, and if it's not just a single value, but it's the trend in the value, and that if we have significant evidence of deterioration of a Glasgow Coma score or 2 or more, or 1 in the motor score, that needs to be reported to the physicians. So you see on the left the Glasgow Coma score, and this is actually the modified score that came out in 2014 by the group in Glasgow. And if you haven't seen it, I advise you to go in. There's a lot of really good education and clarification of how to properly perform a Glasgow Coma score. The other alternative is a tool called the Full Outline of Unresponsiveness, or 4-score. And the advantage of the 4-score is that it not only looks at eye-opening and motor, but it also establishes some criteria for pupils, corneals, and other brainstem assessment, and our breathing patterns to help us with a little more detail about our neurologic assessment. While we're taking care of these patients, we also have to remember to keep C-spine precautions, especially if the patient's cervical spine has not been cleared in the emergency room. So we may need to continue to log roll them, and the patient may wear a cervical collar. And then the other thing is monitoring intracranial pressure, whether we use ventriculostomies or extraventricular drain or a parenchymal monitor. With a extraventricular drain, if we are monitoring intracranial pressure from that, we may have a transducer, or we are controlling the drainage with a prescribed level. So that requires that we maintain a 0 for the drainage system, and then the proper level above 0 to control the drainage. And this needs to be re-zeroed with every change in position. And it should be done with a bubble level or a laser level. Eyeballing it, as some people do, may result in as much as a 2 millimeter change in error in the ICP. We're going to also monitor the output, color, clarity, and of the cerebral spinal fluid. And we want to monitor the insertion site for signs of infection. When we talk about temperature, the goal is really to maintain normothermia. And what you see on the left side of the slide here is that we, depending on where we're monitoring the temperature, may cause variations in what is the temperature. What we really want is to representation of a core temperature. And in this, it's typically either our rectal or our urine that we use, urine catheters that have a probe on, or a catheter that is in a Swan-Ganz catheter. We want to avoid fever. Fever is bad for the brain. It may increase metabolism, cerebral blood flow, and result in an increase in intracranial pressure. The Society of Critical Care Medicine defined a fever of anything greater than 38.3, but this may vary in your institution of what your goal is. And treatment involves treating the source of infection, giving antipyretics, and then various methods, either like ice saline, surface cooling, intravascular cooling, in order to lower the temperature and maintain a normal temperature. We want to also monitor and prevent shivering. And lastly, is we're talking about positioning and prevention of injury. Basic thing is raising the head of the bed, we know will help promote venous outflow, CSF shunting into the spinal canal, and lower intracranial pressure. So our prescribed level is typically head of the bed elevated 30 degrees or more, depending on the patient's situation. We want to maintain a midline neutral alignment. So our patient on the right is in the proper position with nose in line with his umbilicus. These are not good positions for our patients. We want to also remember that turning the patient is good for the lungs, prevention of other complications such as decubitus ulcers, but often nurses worry about this or say, oh, the intracranial pressure goes up. Well, it may go up, but much like when we suction patients, it usually comes back down within a few minutes. And so we can gently turn our patient. It may not be 30 degrees or 45 degrees immediately, but incremental turns of 15 degrees will achieve our goal. It's really very few patients that cannot be turned. And then lastly, other things, monitoring for deep vein thrombosis and use of prophylaxis as needed. That could be compression stockings or chemoprophylaxis. We want to provide range of motion and also splinting. So lastly, in summary, is we want to assess the patient, monitor, intervene, and prevent. So remember the acronym ABCDTP that covers most of what we need to know as a nurse. I just want to conclude to let you know that if you are interested in neurotrauma, I am the chair of a course that is being launched by an organization called Global Neuro. And I invite you to join the course. It is going to have 12 modules, 64 lectures, and 11 skills videos. There will be translation to Spanish. And subtitles in English as well. And this is how, please contact me if you want further information. And I'd like to thank you for your time.
Thank you, Karen. That was a wonderful presentation. And now we have one more speaker, Sister Dorcas. Sister Dorcas and Magawa. And she's a certified nurse practitioner with expertise in management and supervision of medical staff. She's a very skilled nursing staff in inpatient teaching with a strong emphasis in critical care and administration. She's self-directed professional with problem-solving, communication, and leadership skills, and successful in managing time, prioritizing tasks, and improve the quality of patient care. She's multi-skilled and multi-talented, and she has experience as an ICU nurse. And she is from Muhimbili Orthopedic Institute, and she's advanced nurse practitioner attached to Muhimbili Orthopedic Institute, Tanzania, since 2009. And she had her education and training from Aga Khan University, bachelor's in nursing, and from Masters in Nursing in Critical Care and Trauma from Muhimbili University of Health and Allied Sciences, Tanzania. And with great respect, I invite Sister Dorcas to present his report on traumatic brain injury.
Sister Dorcas, are you there?
Yes, I'm trying to look and share my slide.
Sister Dorcas, we cannot see your face.
Sister Dorcas, you want me to share from here your screen, your presentation?
Yes.
I share from here. Can I share from here?
Yes.
Just hold on. Huh?
Oh, thank you so much. I would like to thank the organizing committee for such a tremendous opportunity you have given me to share with you about traumatic brain injury management case report. A 23-year-old man presented at EMD on 27th of November, not December, with the history of being involved in MTA as a motorcyclist. He fell down while driving. He was reported to be drunk. He sustained head injury accompanied by loss of consciousness. No bleeding was noted in the ear, nose, and throat. No convulsions. No convulsions. And also, his chief complaint was loss of consciousness, post-trauma, multiple traumatic bruises on face. Past medical history has history of chronic illness, and also has no history of treatment prior current admission, has no known marriage, and also no family history and social history.
Sister Dorcas,
Yes.
are you sharing your screen from there also?
No.
Because there's echo from your side. You don't share your screen there. I will share from here, okay?
Okay.
Okay, we'll continue.
A review of body systems. Central nervous system, it has ansocoria right pinpoint, 1 millimeter non-reactive to light, and also on his left eye had 2 to 3 millimeters reactive sludge to light. His brain stem reflexes were all intact, and also his GSS on arrival at AMD was I2V1M2. Review of body system, then on integumentary system, has superficial traumatic bruises on the face and also at the back. The rest of the system were essentially normal. A vital signs on arrival to EMD, blood pressure was 173 over 103, which was slightly elevated, but the rest of the vital signs were normal. And also RBG was 60.5 millimeters of mercury. And some of the radiological imaging which was done, chest X-ray revealed to be normal. And the CT scan brain is shown smaller acute subdural hematoma and also brain edema. Chest X-ray for the spine, total spine was normal. Initial laboratory investigations, there was a bit of elevation in WBC, 12.4, and the rest of the parameters and were normal, and also serum electro was normal, blood group was A positive, and also renal function test was okay. Diagnosis was severe TBI with right frontal small acute subdural hematoma and also brain edema. Our goal of treatment was to treat the primary injury and also to prevent secondary injury. Our treatment approach was non-surgical, and also he was planned on mannitol 350 ml start, then 100 ml TDS, and then 80 ml TDS for 3 days. Injection fentanyl was given 1 gram start, then 100 milligram TDS for 5 days. Paracetamol, pantoprazole, and also ceftriaxone was among his treatment. And fentanyl, 100 microgram was given TDS for 48 hours. Was also kept on normal saline, 120 ml per hour for 24 hours. On nursing management, the patient was intubated due to low Glasgow coma scale, and suctioning was done PRN, catheter was inserted, nasogastric tube was also inserted, and monitoring of intake and output was carried on. Hemodynamic monitoring was done every 30 minutes. The patient was admitted to ICU on the same day, and on arrival to ICU was intubated and sedated, but 2 hours later was evaluated and his Glasgow coma scale was I2-VTM2, and also central venous catheter was inserted, and he continued with the planned treatment. The positioning of the patient was positioned, and also the neck was kept on neutral position. Head of bed was elevated to 30 degrees, was nested on air mattress to prevent bed sores, and also turning of position was done. He was kept on a high protein caloric diet, monitoring of intake and output carried on, monitoring of blood glucose levels was done twice a day, suctioning was done PRN, and the care for catheters inserted was done aseptically. Open wound dressing was done on superficial bruises aseptically, and also monitoring of increased ICP was done, observing features of increased intracranial pressure, because in our setting we don't have ICP monitoring device, and also normal saline was given 120 minutes per hour for 24 hours. Hemodynamic monitoring was done 30 minutes, every 30 minutes, and the targeted systolic blood pressure was 140 to 170 millimeters of mercury, and our patient was ranging from 128 to 173. Targeted diastolic pressure 90 over to 110 millimeters of mercury, and our patient was ranging from 80 to 103 millimeters of mercury. Targeted temperature was below 36. And our patient was ranging from 36 to 37 degrees centigrade. Targeted oxygen saturation was greater than 95%, and he was ranging from 94 to 100%. Blood glucose levels were within a normal range, and neurological monitoring was done hourly, including pupil examination. Pupil size were improved slowly and returned to normal on 3rd of December 2023. Administration of prescribed medication was done timely. On 29th of December, he was reviewed and planned on start physiotherapy. And on 4th of December, he was noted to have no much improvement in GCS, and I was 2-VTM3, but vital signs were normal. So he was planned for control CT, serum electrolyte, blood gas, and also analysis. His control CT scan revealed normal brain CT scan. On laboratory investigations, gas was within normal range, but on serum electrolyte, he revealed the sodium was elevated to 156. but CBC was within normal range, and also urinalysis parameters were normal. He was and also was given dextrose 5% at 125 mils per hour per 24 hours. Reduced the salt intake, and daily monitoring serum electrolyte was done. He was also kept on seraptopeptides 10 milligram TDS-CBD. Fentanyl was changed to carbamazepine 200 milligram NOCT, and ENT specialist was consulted for electrotracheostomy. On the 5th of December, serum electrolyte was 150 millimoles per liter. And on 6th of December, serum electrolyte was 142 millimoles per liter. And his GCS improved from I2VT M3 to I4VT and M4. Patient was planned for tracheostomy. On 7th of December, GCS was same GCS I4VT M3. Patient was weaned off from mechanical ventilator and kept on TPs and maintained good saturation of 95 to 97. And his serum electrolyte was 140. On 8th of December, a tracheostomy was done, and post-operatively, the patient was kept on tracheostomy mask with a good saturation. On 10th of December, patient improved and he was transferred to HDU with a GCS of I4VT and also M5. And this is our more severe TBI management protocol as John.
Yeah, thank you, Sister.
Thank you so much for listening.
Thank you, Sister Dorcas. That was a very good presentation of a traumatic brain injury case.
Thank you so much.
Now I invite the commentators to give comments and their suggestion.
Okay, I am again asking, can you hear me clearly?
Yes, yes, please.
Okay, now I want to share my observation. I have no question. My first observation is directed to Sister Karen March, that you have highlighted briefly of clinical and management profile in case of traumatic brain injury from your perspective. So beautiful presentation, I must say. Just one point I want to add, that this clinical profile differs slightly between adult and pediatric population. And so far I have seen you have highlighted all the profiles directed to adult population. So if you briefly discuss what is the difference of clinical profile in case of pediatric population, I think it would be more fruitful for the audience, because mixed type of audience is here. So it would be beneficial. That's my point of observation. To Sister Karen March, can you hear me?
Yes.
Okay.
Well, thank you. You know, I think you have to keep in mind that with pediatrics, the care of the patient is based on weight-based.
Yes.
The complications are the same. And so the approach, yes, is going to be similar, regardless of whether it's an adult or pediatric, other than what exactly the signs are. You know, in a pediatric patient, you would need a Glasgow Coma score age appropriate for your assessment. And there are, I actually like the Adelaide scale because it's something that can take you through infancy to adolescence, where there is a pediatric Glasgow or an infant Glasgow Coma score, which is very targeted to the child who is really non-communicative at that point. So I think you have to tailor all of your aspects to the pediatric population. So I do appreciate that. I did add some of that information in there.
Thank you. Thank you very much for considering my points. Thank you very much.
Okay. Now coming to the closing remarks, I should say that both the speakers, nursing speakers on traumatic brain injury nursing perspectives, discussed by Ms. Karen S. March, was a wonderful presentation. She has highlighted almost all the important aspects of caring for a patient with a traumatic brain injury in the acute period. And she has also explained it very clearly using the acronym ABCDTP. The basics of TBI care was explained well. And she has highlighted that the primary goal of nursing management of patients with a head injury or traumatic brain injury is maintaining adequate cerebral perfusion, improving cerebral blood flow, and preventing cerebral ischemia, and thus preventing secondary injury to brain. So that she has highlighted well, and she has stated the importance of nursing care in the acute management of traumatic brain injury. And coming to the second speaker, Sister Dorcas, she has very well presented a case on chronic subdural trauma. The acute period management was discussed in detail with the patient scenario, and towards the end, the patient was and when the patient was shifted to the high dependent unit successfully. That is also a very important aspect of the acute period management. So we all know that traumatic brain injury from the acute period up to the rehabilitation part, nurses play a very vital role in managing traumatic brain injury cases. So we should realize our role and work towards attaining a good output and bringing out better quality of life for traumatic brain injury patients. Thank you.
Any more question? Any burning question? Professor Yoko Kato, any
Yes.
comment?
Thank you so much. So the Sister Karen and also the Dorcas, it was wonderful talk. Just I want to ask, in your country, for severe head injuries, do you have a hypothermia treatment for severe head injury case? Just I want to ask.
Do you have what? May you say, would you?
Yes, hypothermia.
Hypothermia.
Yeah.
I'll answer that. We do on very selected patients with head injury. It's very individualized, since most of the studies that have shown any benefit for hypothermia have been very selective, and it's really the focus nowadays is normothermia, other than for cardiac arrest.
Okay, thanks. So what about the Dorcas in Tanzania? Sister Dorcas?
Yes.
Do you use the hypothermia?
Hypothermia.
Hypothermia.
So use
Actually, we try to keep the patient cold.
Yes.
We have
with cooling blanket or so on.
actually we don't have cooling blankets, but sometimes especially if patients they have high temperature, which is a central fever, we normally use cold IV fluids. We keep them in the fridge so that we can cool them. And also our ICU have got air conditioning. We make sure our AC is on and working proper so that to create a cool environment for our patients. That's how we do.
Okay. Thanks so much. Miss
Dr. Fahad, you had question to Sister Dorcas. Can you please forward the question? Dr. Fahad. Sister Lucas, this question addressed to you. What is stereotopeptides used for post-operative period? Sister Dorcas?
Yes.
You may read the question from the Q&A session from Dr. Fahad. what is stereotopeptides used for post-operative period? You see from the Q&A.
Yes, yes, I have seen. Normally, we use them as anti-pain and also anti-inflammatory to patients who deserve to be used in that medication. Because it's an anti-pain and also anti-inflammatory.
Dr. Fahad, is it answer your question?
Thank you. Thank you for the answer.
Okay.
Nice presentation.
Thank you. Any more questions? If none, I would like to invite Prof. Yoko Takato to say a few words before we close the session.
Okay, thanks so much. So the both speaker of the sisters, still the head injury, especially the severe head injury, still we don't have a breakthrough the treatment, I think. So that's why still we need more research and more accumulate clinical cases, I think. So thank you very much. It was a very wonderful talk, conversation. And also the MC, the sister Asha, thank you very much from India. And of course, Dr. E, it was the excellent talk. Thank you very much. You should more involved of the hands-on of the Asian Congress.
Okay, thank you.
Dr. E, thank you so much. Thank you.
Thank you, Professor Kato.
We have come to the end of the webinar. I'd like to thank all the speakers, the chairs, and the commentator for the wonderful session. So thank you very much for all those who have joined us. And we have a wonderful session. We'll meet again the next webinar, probably next February, because now it's already mid of December. So I take this opportunity to wish everyone happy Christmas and a Merry Christmas and Happy New Year. Okay,
Happy
see
New Year.
all of you. Thank you very much.
Thank you.
Thank you so much. Okay,
Thank you.
see you again.
Thank you.
See you again.
Bye-bye.
Bye.
Bye.